Welcome everyone to the April 16th COVID-19 clinical care rounds focused on emergency department patient care and clinical operations. My name is Richard Hunt. I'm an emergency physician who serves as senior medical advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer real-time sharing of COVID-19 emergency department challenges and successes in patient care and operations. If I'm an emergency physician preparing to care for many COVID-19 patients, the clinicians I want to learn from are those who have the most experience. This is a voluntary public-private collaboration, and our thanks goes to those of you and your professional organizations who have collaborated on these rounds. They are not intended to be redundant or replace any organization's initiatives. They are intended to be a sharing of clinical experience, but not recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges in patient care with other clinicians. Our appreciation goes to NETEC, the National Emerging Special Pathogen Training and Education Center, for their support with these rounds, and to Project ECHO, Dr. Bruce Strumminger and his team for the peer-to-peer learning platform we're using for these rounds. Upcoming ECHO COVID-19 clinical rounds currently are all US noon Eastern time. Monday, April 20th will be clinical rounds on EMS patient care and operations. Tuesday, April 21st, COVID-19 clinical rounds on critical care, life-saving treatment, and clinical operations. The cycle that we've established for the at least foreseeable future are Mondays EMS, Tuesdays critical care, Thursdays emergency department, all noon Eastern time in the United States. When we send out announcement for upcoming rounds, sometimes you'll see speakers to be determined rather than already identified. And that's because we work to identify speakers just in time, given the rapid changes in experience with the pandemic. For the ECHO rounds we've had to date, we've had participants from all states and many countries, predominantly physicians, nurses, and EMS clinicians. We've noticed an increase in participation by clinicians from other countries. We've had speakers who have generously shared their experiences from Singapore and Germany, and for the last rounds on critical care had participants from approximately 30 countries. This disease knows no boundaries, and it's gratifying to see clinicians from across the globe learn from each other, always focused on the patient. We're very much interested in making this more interactive, continuing to engage expert discussants, our panelists who are on the Hollywood Square-like tiles, and also crowdsourced polling. We received many pages of questions, this time around to where it's like I thought my printer was gonna run out of paper. 558 questions, and apologize in advance that we will not be able to cover all those questions. We have, however, picked out some major themes and hope to cover some of those. This peer-to-peer learning platform allows us to have speakers and panelists who are leaders in their field by video, and that's who you're seeing on your screen. Please use the polling in the chat room to crowdsource it. And at this juncture, I'm going to turn it over to Dr. Bruce Strumminger from Project ECHO.
Great. Thank you, Rick, and welcome everyone. Welcome to our panelists and to all the attendees for joining us today. Just a few housekeeping items. First, please reserve the Q&A function on Zoom for questions and comments regarding the presentations. Use the chat function for questions regarding technical or logistical issues. We'll also be putting information about getting your CME there. And I just put some questions that we're hoping to crowdsource, which Rick will go over in just a moment. The slides and a link to the video recording will be shared after the session via email with everyone who registered. Presentations linked to the most recent announcement also include links to the recordings and PowerPoints from previous sessions. This session is being recorded and your attendance is consent to be recorded. Thank you for that. There will be CME and continuing professional development credits. They'll be available through the University of New Mexico via a link in the chat at the end of the session. So about 15 minutes before the end of the hour, we'll put that link there. That we want you to take advantage of that. We also want your feedback. There'll be a short survey, and that's the way we will get your feedback so we can improve these rounds as we move forward. I'm actually going to put up a slide here and ask Dr. Rosha McCoy if she wants to say a few words about the AAMC COVID-19 guidance repository. Rosha?
Sure. Thank you so much. Yes, we continue to update the COVID-19 clinical guidance repository with new documents as they are sent to us as the pandemic evolves. We have new materials on management of VTE and renal replacement therapy as those are becoming more important. We also have a section on serious illness conversations and palliative care. So we just encourage folks to keep going back to the repository because there's no new information being uploaded. And we're also working on uploading some alignment documents that looks at where there's alignment between institutions on how they're approaching the clinical care of patients with COVID-19. So any questions, please let us know, but we hope this is helpful.
Great, thank you, Rosha. And now, Rick, I'm gonna go back to you to review these crowdsourcing questions.
Thank you, Bruce and Rosha. There are some crowdsourcing questions that we have, and these really are helpful to know exactly what is going on in the country and internationally as well, with reference to the COVID-19 response. First, are there drugs shortages in your emergency department? That's a simple yes, no. If yes, which drugs are you short of? And then your state. Then second question, what's been the best change in your ED operations in response to COVID-19? It's a little bit more global question, but we've actually gotten some really fascinating and innovative responses to that kind of question before. With that, please do the chat, please do those questions. It's really important for all of us to see what's going on. At this juncture, I'd like to introduce our Dr. Mike Winters, a professor in the Department of Emergency Medicine and Internal Medicine, and is a leader in the field of critical care in the emergency department. He is the editor-in-chief of the Textbook of Emergency Department Resuscitation of the Critically Ill, and is the founder of Emergency Medicine, Internal Medicine, and Critical Care Training Program at the University of Maryland Medical Center. Dr. Winters.
Thanks very much, Rick. Let me screen share here. All right. My thanks to everybody for joining in today. A really huge thanks to Rick for the invitation, Bruce, Project Echo, Amanda for allowing me the opportunity to participate in this discussion that I've very much been looking forward to over the last several days. As Rick indicated, I am at the University of Maryland Medical Center in Baltimore, Maryland. I'm currently our vice chair for clinical and administrative affairs, so I help to oversee operations across our 13 EDs and hospital systems. Just by way of background, I have listed my email at the bottom of this slide, and I think you all have a PDF of these slides. So if there's anything from a content, protocol-wise, or individual questions that any of the participants have following this discussion, I'm happy to receive any and all emails. This is just going to be a few introductory slides by way of a higher level discussion of what our experiences have been at the University of Maryland and across the state. And then I think there's a lot more granular questions that I'm looking forward to discussing soon. In terms of the University of Maryland medical system, we currently employ about 26,000 individual employees. We have about 4,000 physicians, 150 clinical sites across the state, and we have 13 hospitals with the main hub at the University of Maryland Medical Center, which is where I currently practice. In terms of Maryland overall, just to kind of level set everyone where we stand currently in the COVID epidemic, this is from our master tracking board that we follow daily through our incident command system that really refreshes and updates every 15 minutes. Now, this is a snapshot of our dashboard across Maryland, and that was 24 hours ago. So within the last 24 hours, we've had an increase of 1,000 COVID positive cases, and in the last 24 hours, we've also unfortunately had an increase in deaths by approximately 120. So we are now at total deaths about 420 and rising today. What we've noticed across the state with our various EDs is that it is very much pockets of activity. And you can see here by the various counties in Maryland, it's really concentrated significantly in the Prince George's DC area, and a little less so, but still heavy in the Baltimore City region. We've described it internally as almost more of a popcorn effect, where various regions of the state have gone hot at various times throughout this epidemic, and these are the current hot and active areas. What we are challenged with most at this time in Maryland is the rapid accumulation of cases within our skilled nursing facilities and assisted living centers. And I'll get to this in just a few minutes about what we've done to try and combat or attack that issue. But we've had market increases with a number of skilled nursing facilities that are calling out to the state, to our Maryland Institute for Emergency Medical Services, asking and needing clinical help at these facilities. So that's what we're currently struggling with at the moment. Our experience is going to be a little bit different than what you'll hear from Eric with respect to New York City. I feel that we've had a little bit of a lead time in terms of our own preparations in Maryland and across our system, with the initial cases out west and then popping up in certain other areas of the country. It's allowed us to really get our hands around, leverage the technology, set up a very comprehensive incident command structure, and therefore allowed us also to develop a whole lot of clinical protocols. We've also, like everyone else listening, have been able to crowdsource and have really participated and benefited from the advice, the recommendations, the clinical experience that many of you have sent in, not only on social media platforms, but ACEP leading the way in terms of its manual and leveraging a lot of experience thus far to help us prepare. One of the biggest things that we have learned over the course of the last 6 to 8 weeks is simply the team effort across our medical system. It has been like unlike any other time that I've experienced in my 20 years at the University of Maryland Medical System. It has really been a true collaborative effort across the system, across the state, and really across the country. So I'm certainly proud to call myself an emergency physician and partner with all of you in this fight against COVID. Just a few specifics of what I think we've been able to do that has helped us manage the surge that we are currently experiencing at the University of Maryland. Very early on, we were able to establish a fairly robust incident command structure, and that really has been at the higher system level. We've had an incident command leader that is an emergency physician within the military, and so we were able to set up a significant amount of standard operating procedures that then that incident command structure was replicated at each of our 13 hospitals, and we have a fairly consolidated reporting structure. We've also leveraged the technology, information technology we have in our electronic health record to really stand up very quickly a very robust dashboard that each morning we're able to review on an incident command call that gives us insight across the system about our bed capacity, our PPE burn, our ventilator utilization, our lab testing, as well as the demographics of our positive cases, how many we have in-house. I can say that of about 5 hours ago, we have about 230 positive patients currently in-house, not simply tested positive, but those that have been admitted. And about 40% of those are on ventilators and in the intensive care unit. To that end, this is our ED component of that major dashboard. So across our 13 emergency departments, I'm able to at any time dive into this reporting structure and see specifically what the hourly arrivals have been at those sites, what our ED waiting rooms look like, and then what are the total number of active patients between those that are admitted, those that are undergoing testing, and those that are simply in our waiting room. So it's provided us a lot of insight and helped us to really load level and see where the challenges are, which EDs in our system truly need help. And really, two of them have stood out in the last 3 to 4 days, and that has been our ED at Prince George's Hospital as well as our ED at Baltimore, Washington. Also leveraging the technology and allowing us having that lead time, we were able to stand up over about a week's time what we have felt is a fairly robust telemedicine, teletriage initiative. So what we were able to do quite rapidly is deploy telemedicine technology in the form simply of iPads to all 13 sites. We were able to put together a telemedicine or teletriage hub at the medical center in our administrative building, where we've got about a 12-hour teletriage coverage. 3 emergency providers sit in there. They look into all the triage rooms of our EDs, and then with our triage nursing staff are able to rapidly assess patients, initiate diagnostic orders, and then, as all of you know, with respect to the 1135 waiver, we are now in the process of discharging many patients following a tele-triage visit directly from the emergency department. So that we've been able to leverage and felt has given us a lot of opportunity to meet the demands of the arrival of the surge, but also conserve PPE and conserve exposure with a lot of our healthcare team. We are now branching out with respect to telemedicine and looping and including ED callbacks. So I would envision that many of you are probably discharging folks that previous to now or the last several weeks you would have admitted that may have required some degree of supplemental oxygen. We are in the process for those higher risk ED discharges of connecting them and scheduling telemedicine follow-up with our ED providers. So that has been able to allow us to more appropriately admit higher risk patients. In terms of specifics with patient care, early on, we implemented a process whereby we were able to separate our waiting room populations. We implemented teletriage very, very early. I think all of us have probably been drinking from the fire hose of information, daily emails, and the deluge of communications. So we quickly put together just a single communication process to limit the email dings and everything that we're trying to process throughout the day. We have a singular communication that goes out in the evening across our physicians, APPs, our nurses, and our nursing technicians to standardize and consolidate that communication with any particular update. And I would also say that fairly quickly, we went into an aggressive PPE change, understanding that there are limitations of PPE burn and supply, but we quickly, recognizing the exposure of ED providers and physicians and clinicians, we adopted fairly early universal masking a few weeks ago, and I think that's helped to mitigate any healthcare worker exposure and our total number of healthcare cases. In addition, we've been able to put together or had the time to put together cardiac arrest protocols, minimizing folks in the room. So we have a fairly robust protocol around people who either arrest in the ED or who come in arresting. We have an intubation protocol for airway management, critical care management guidelines for the ED that does include self-proning. And we've also leveraged some very good relationships we've had with our EMS colleagues about how we receive patients coming in from our EMS colleagues, and have recently instituted some palliative care initiatives within our emergency department. The things that are challenging us at the moment, and then this is my last slide before turning things back over to Rick, are those atypical presentations. We've certainly had a few folks come in critically ill that turn out to have a pulmonary embolism but end up testing COVID positive. We continue, like all of us, to evolve our respiratory management and the now pulling back a little bit on early intubation and using some of that non-invasive ventilator strategy. we've struggled with our higher risk service lines. So we are a primary transplant and oncology center in inner city Baltimore. So how do we separate those patients out? We've addressed ED boarding recently, that as of 2 days ago at our medical executive committee, it was unanimously voted on that the ED attending now determines the service that will be admitted, and that service has 1 hour to place admission orders, and the patient is transferred out of the ED to allow us to receive incoming patients. And then those high-risk discharges that, once again, I mentioned that we're now helping to mitigate through the telemedicine initiative and strategy. So those are some of the things that we've done here at Maryland. I'm interested to see what Eric has done up at New York Health and Hospital, and then the discussion that will ensue. So my thanks once again. That's a higher level for us at the University of Maryland.
Thanks very much, Mike. You covered a lot of ground and a lot of the issues that we've seen pop up in questions in previous rounds and in the dialogue in previous rounds. Okay, so one, there's so many to choose from. But one that I think would be especially pertinent, given that you are seeing a lot in an entire system rather than just your emergency department alone, the dashboard, the EMS interface. If you were to, this is sort of like a double-edged question a little bit. If you were to say to EMS across the world, you know, it would really help us in the ED if you did this, what would that be? And then the other is, it's the other way around too. It's like, what can emergency departments do to be most helpful to EMS providers?
It's a great question. I don't know if I have all the answers. I can tell you what our experience has been. When we have these incident command calls each morning or certain points throughout the day, we have our EMS leaders, select amount, participate in the incident command, so they also see what's going on across the system and they have insight. They know where the difficulty and the pain points are, so they are included in part of those in our system calls. It's been very helpful. We've also, because of the involvement of those leaders within our information and discussion, we have established some protocols whereby, I know we all have base stations and then our EMS colleagues radio in when they're bringing select patients in, but more often than not, we receive a lot more pre-hospital communication that patients are coming inbound. We have a protocol whereby instead of them coming into the ED, we have a select number of staff that meets them at the EMS entrance. We also assist with them in terms of doing a quick screen to make sure that the patient is properly masked and has the appropriate PPE. It allows the EMS provider to maintain their degree of PPE integrity, and then we will take the patient right from the EMS entrance. So our colleagues can discard their PPE, clean the unit, and then rapidly get back into service rather than waiting 10, 15 minutes in some degree of an EMS queue while waiting for the charge nurse to get to them.
Thanks, Mike. There's another reason why I asked that question. It's been fascinating. We do a series of rounds on critical care, EMS, and emergency department, and uniformly we get at least 25% of the participants are EMS, and they have asked many times with these questions, what is it that we can do to help the most, so forth, so on. So it was very targeted at that specific issue, because I know they like everyone is trying to like do their best in this response. Let me go ahead and move on to our next speaker. Before I do so, though, I want to get back to the crowdsourcing questions, and really appreciate the answers I've seen pop up through the first 20 minutes or so. But number one question, best change in your ED operations in response to COVID-19. The second one is about drug shortages. Yes or no, drug shortages or not? And then if yes, which drugs are you short of? I've seen fentanyl, I've seen paralytics pop up, some others as well. Oh, albuterol, I saw it pop up. But please answer, and a no answer on is just as valuable as the yes. And then the state that you're from. so we can at least localize that. With that, I'm going to turn this over to our next speaker, Dr. Eric Way, Vice President and Chief Quality Officer, New York City Health and Hospitals, and a practicing emergency department physician and Hicks lead for emergency medicine. Eric.
All right, thank you, Rick. And thank you, Amanda, for driving the slides for us. I want to give my thanks to Bruce, the ECHO team, and everyone on here, and thank you for the opportunity of sharing a little bit about New York City Health and Hospitals and our COVID-19 experience. I'm joined here by Dr. Dave Silvestri, a Senior Director over Care Transitions, as well as Medical Director for Utilization Management in the Office of Quality and Safety here. So go on to the next slide, please, Amanda. So no financial interests or relationships to disclose here. Next slide. I think, want to take a moment here to say that our thoughts, our prayers, our hearts go out to everybody whose lives have been turned upside down by this terrible virus, COVID-19. To anybody who's lost somebody or is in the ICU fighting for their lives, you are why we show up every day, fighting this war against COVID-19. But above all of that, it really is our fallen colleagues, the healthcare workers, doctors, nurses, and everyone who supports the doctors and nurses. And so I've never been more proud to be a healthcare worker and of all the heroism I've seen over the past 6 weeks or so. Next slide, please. So a little bit about New York City Health and Hospitals. We're the largest public healthcare system in the United States. Los Angeles County is the second largest, and that's where Dr. Mitch Katz and I came from before coming to New York City. We have 11 acute hospitals, 5 skilled nursing facilities, 70 plus ambulatory clinics. Metro Plus is our public insurance plan. We cover correctional health services, home health agency. We serve over 1.1 million New Yorkers every year. And we're also the home of NYC Care, which is guaranteed health care to all New Yorkers. And core to our mission is the without exception piece. Anybody who comes through our doors, no questions asked. We want to provide the highest quality and the safest patient care. Next slide, please. And so when the mayor of New York City said that we're the epicenter of the epicenter, that really is New York City Health and Hospitals. We are the public system with the most facilities in the 5 boroughs. The COVID-19 virus disproportionately affects our patients, the most vulnerable, the poor, those who had comorbidities going into the pandemic, those who are living 8, 10, 12 people in single room apartments. So not only is the virus running through families and neighborhoods and communities, but also the social distancing measures is disproportionately affecting our patients and their children who are out of school, who are struggling with eviction and how to put food on the table. I included a heat map. This is about a week old at this point, April 3rd, maybe a little over a week old, showing that it has not been evenly distributed across New York City. And it really is the poorer neighborhoods, Queens, Brooklyn, South Bronx, whereas Manhattan has been relatively spared. Some of the hospitals of ours that have been hardest hit: Elmhurst, Lincoln, Queens, Woodhull, Coney Island, Kings County. This is the borough of Queens, this is South Bronx, and this is Brooklyn. Next slide, please. So, first case was March 1st, and realizing that we had such a large system with 11 emergency departments, we knew that it would be difficult to kind of set up a nimble enough leadership structure through the existing ED Council that has about 60 people on it right now. And there were so many local meetings and departmental meetings and just trying to deal with the fire hose surge of patients coming in the front door There was no way to pull in 11 ED chiefs and nurse managers together. And so we decided to pull together a smaller, more nimble team with wide representation, tapping kind of one or two levels below the ED chief, the associate directors, and some frontline clinicians who had emergency management or disaster backgrounds, tapping into our central office emergency medicine physicians as well. This ED COVID action team started meeting twice daily at 8 a.m. as well as 6 p.m. There was formal representation of this team on our HICS command structure, as well as formally in our central office leadership structure as well. There was full ED Council meetings 1 to 2 times weekly. We actually found the weekends were the best time to get the most participation on these, and that was bilateral communication. We also send out weekly email updates, but this ED COVID action team was really informed and driven by what we were hearing from these full ED Council updates and meetings. Tell us what is keeping you up at night, tell us what your biggest concerns and fears are, and let's set goals around those. Go on to the next slide, please. So just a shout out to the ED COVID action team members here, all emergency medicine physicians, pediatric emergency medicine, as well as disaster and emergency management folks here. Next slide. So these were initial goals that we set out to accomplish, and this was based off of feedback from the ED chiefs. And so I'll just go over these very quickly. I definitely cannot do justice to the amount of work done by this action team, by the ED leadership, by the frontline doctors and nurses in 10 minutes. But I'll point out a couple highlights. So goal number 1, decant volume from within the emergency departments. So this is early on. What Elmhurst, what Lincoln, what Queens were experiencing was more than double your daily ED volume. And you couldn't get through the mild and the asymptomatic to get to the moderately and the severely ill before they were collapsing in the waiting room. And so some of the things that we worked on is before they even set out to come to the emergency department, let's give them a phone number to call. So 311 was handling hundreds of thousands of calls around COVID-19. I think the peak we had something like 700 doctors answering these phone calls, 311. We also worked with FDNY to divert 911 calls. So these are guaranteed, 1-for-1 ambulance transport to one of the emergency departments in New York City, unless we convert it to a phone or video telehealth visit, and hopefully prevent some of these ED visits. Public messaging was another huge part of this. We have a Notify NYC kind of text message that sends out messages daily. We were able to get some of our messages into that system. We wrote an open letter with the help of Dr. Karen Rhodes to all New Yorkers from the emergency department front line. We have almost 3,000 signatures on that. But to get the messaging out of not just stay home, but a more nuanced of stay home, look out for these warning signs like you would for a heart attack or a stroke, call your doctor. If you can't call your doctor, call 311, and they will guide you of whether or not you need to come to the emergency department. And then once people came to the emergency department, we were operating under a modeling structure, or shared mental model of we need to turn our 11 hospitals into giant ICU buildings. We need to convert our emergency departments into giant critical care resus pods, right? And so keeping those who are asymptomatic or mildly symptomatic out of the building became a priority. And so what we did was put providers out front, sorters, using Epic for as long as we could with informatics tools, a 3-minute note, order sets, and be able to do everything in 2 to 3 minutes for a low acuity COVID patient. That was very helpful. At some points, we did have to switch to paper MSE, a temperature, a pulse ox, and pointing towards a tent, or pointing towards an urgent care, or pointing towards somewhere else where our orthopedic doctors were repurposed to see ortho complaints. So keeping the mild and asymptomatic out of the emergency departments was a priority. For those who are moderately and severely ill, we want to get those in right away. And so that was part and I'll get into some of those algorithms in a second. Goal number 2, prevent and minimize quarantine on existing ED staff. And so I think Mike touched on this a little bit. We just had to quickly throw all those assumptions that we could screen for COVID and we could isolate COVID out the door. We just had to make the call that our emergency departments are hot zones, assume anybody who comes in via EMS or the front doors could be COVID positive, whether that be a car accident trauma and you put them into the CT scanner and they have ground glass opacities, or somebody that you saw on fast track. And so what we did is made a call very early on to declare the emergency department's hot zones and get people into full PPE, including N95s and eye protection. Working with the Department of Health here, we had to quickly move away from the 14-day quarantine for anybody exposed to somebody positive for COVID. At some point, you just assumed if you lived in New York City, you were exposed to somebody with COVID. And so basing that more on symptoms than just exposure. I think pausing here to say that protecting and supporting your staff is probably the most important thing that you can do here. Get them into N95s, provide emotional and psychological support, bring comforts to kind of reduce the burden, whether that be sending meals, giving them hotels to stay in, transportation at night when it's more difficult to get a taxi or an Uber, anything to kind of lower the burden when they're working extra shifts, extra hard to treat COVID patients. 3, we want to expand the staffing model outside of existing ED staffing to meet the surge. And so here we started with a volunteer corps within health and hospitals. And so this is signing up our APPs and our attendings into this volunteer group and saying, right, we know that your ED is not hit as hard. Would you be willing to pick up extra shifts working at Elmhurst or Bellevue or Lincoln? And so that helped get us through a week or so before kind of the cavalry came, before the Army, the Navy, the Air Force, before we could get volunteers from other states, as well as vendor paid providers to help with the staffing. Another piece of this is repurposing OR staff and ambulatory staff that, as we close clinics and stop doing elective surgeries, could they come down and help sort? Could they come down and help transport the critically ill or even manage the ventilators and boarding ICU patients? 4th goal was to free up new and existing ED space. So we took over all of our pediatric ERs, a lot of our psychiatric emergency room spaces, and this was building space for surge. So both for boarding patients, for observation of patients in the emergency department, but we needed to create additional physical space for all these patients. Protect supply of vital equipment. So hearing back of what we were running low on, working hand in hand with our supply chain to make sure that we had the PPE and the ventilator replenishments to each of our emergency departments and facilities, and escalating things that we were worried about. And then number 6 was minimize burden surrounding reporting. So I talked a little bit about the informatics tools, the order sets, the COVID screening note, the rapid MSE, discharge paperwork in 12 different languages, turning those into handouts that our sorters could hand people who were being sent away from the front door, or as we started screening at every entrance to our buildings. And so decreasing kind of the documentation, as well as communication to our frontline residents, nurses, doctors, having a Google Drive of the best practices and the latest protocols. Go to the next slide, please. So I'll let you read through these. This is what we prepared for. So a yellow surge, a red surge, and a black surge levels based off of the modeling that we were expecting in New York City before the New York stayed on pause. Social distancing went into effect and successfully flattened our curve. So this is for the moderate and the critically ill who were not sent away from the front door of the emergency department. And it's based off of your pulse ox, comorbidities, and a workup, including chest X-ray and labs and EKG, would determine whether you get admitted or placed in extended obs or discharged. If you go to the next slide, this is kind of our intermediate, so red surge, if you could not keep up with all of those studies. So it's a more accelerated decision-making here. And then the next slide. And this is black. This is when you are just completely overwhelmed that you don't even have time to draw blood or get a chest X-ray. So this is what we were preparing for. So based off of respiratory status and your pulse ox, making decisions on who stays, who gets intubated, and goes to the ICU. So this is our preparing for the worst. And thankfully, we never had to reach this black surge level, but that's what we were preparing for. Next slide. So to quote one of the great philosophers of our time, Mike Tyson, everyone has a plan until they get punched in the mouth. And so this is what our ED COVID action team realized very quickly, is that you can plan all you want, but we definitely got punched in the mouth in many of our emergency departments. And then some of the interventions that we put together when we had double the volume coming to the emergency department, such as the front end sorting process, using the testing tents, seeing mild ILI outside of the four walls of the emergency department, by week 2, they were completely outdated. Our volume was down to half of normal daily volume, but everybody coming in seemed like they needed to be intubated. And so being able to pull those resources back and move them into more of critical care, kind of boarding vented patients in the emergency department, that became, weeks 2 and 3. Shifting from the no BiPAP, CPAP, go straight to early intubation to let's do everything we can to prevent intubation, including let people stay on high flow nasal O2 with SATs at 70% and 80%, things that would shock us 2 months ago. So I'd say this is the biggest thing, is that you want to plan, but at some point you just have to be nimble and adaptable to the ever-changing. I think Mike mentioned this, right? Things could change from the beginning of one shift to the end of your shift in terms of what the expected practice is. All right, next slide. Now, the last point I'll make here, I think we feel fortunate and lucky in that we are a large system. And so we leverage that to level load, flattening a different type of curve than the social distancing, public health strategies. We wanted to flatten the COVID-19 surge across our system. So not allowing Elmhurst to just take it on the chin and get to 200 ventilated patients. What we did is we streamlined our existing transfer process to allow for high volume batch transfer. So moving 20 med-surg patients at the same time and giving handoff on 20 patients rapidly, moving 5 ICU patients at the same time and giving handoff quickly. This was data driven. These were the 4 data elements that we were looking at on our dashboard: number of boarding admissions in each emergency department, the med-surg occupancy rate for the hospitals, the ICU surge level as determined by the ICU directors, and then the total number of ventilated patients in the hospital as well as boarding in the ED. And in 3 weeks, we were able to move 715 patients across the system, more than 500 med-surg and more than 150 ICUs. And so this was allowing some of our Manhattan hospitals to rise to the occasion and help carry the water that our Queens and Brooklyn hospitals were feeling with the COVID surge. And so in terms of working together as one system to save lives, I think this is probably one of the most impactful things that our team was able to do. And we were also able to take patients from standalone hospitals in New York City, knowing that they did not have that same luxury to level load across the system. Next slide. And I just want to end with, I think we're cautiously optimistic in New York City that we've seen a plateau The fire hose coming in the emergency department seems to have been reduced to a trickle. We know a lot of this is due to the social distancing measures. And while we have a little bit of a breather here, we want to kind of regroup, take the lessons learned, and prepare for the next wave, because we expect as social distancing is relaxed, that we'll be having rolling hills or rolling waves from here on out until there's more definitive kind of vaccine or testing available to control this. I just want to say thank you to all the emergency providers, the first responders, EMS, the nurses, other healthcare workers. Thank you for what you do.
Thanks very much, Eric, for your presentation. Dave, you joined Eric here in the room on the panel. As Eric was presenting, anything that boy, that was like the biggest deal, and I didn't know it was the biggest deal. Could you comment on Eric's presentation?
Yeah, a couple things stand out. I think the first thing, what Eric mentioned about the disproportionate impact on vulnerable populations, I think can't be overstated. We have done our level best, and yet, every day I think we still realize how much more we could do in trying to reach populations where people don't have health insurance and don't speak our language and don't have documentation status and live in a home, as Eric mentioned, where there's 1 bedroom and 10 people. And it's difficult. And those people, I think, very early knew that something was going on. Highly international population. There's a lot of talk about whether or not COVID-19 was actually, in New York City and some of those areas well before we knew it. And so we saw the growth. And I think one of the things Eric mentioned, but I think really, really, really important, is making sure that our healthcare settings do not unintentionally become a nidus for disease transmission. And so getting people out of the waiting spaces where some infected people are inadvertently spreading to other infected people through the process of having front-end sorters, I think was truly life-saving as well. Eric talked about it in terms of a little bit more of the operational impact and how that freed up ED resources, ED space in particular, but it's also has tremendous public health value as well. So again, getting those sorters out there, letting the people who are healthy enough to go home without sort of hanging around other people who may be ill, and then bringing that back to their families with the 9 others in their apartment. I think that that's a huge issue. I think this level loading issue that Eric talked about is tremendous. I mean, what Eric hadn't mentioned is that most of our ICUs right now, across over half of our ICUs, are sort of at their peak or next nearest peak level in terms of their surge capacity. That would, I'm not sure we would have been able to handle that without moving those 150 ICU patients or those 500 med surge patients. And so figuring out, many of you all listening are part of multi-hospital systems, are part of, have partnerships with other different hospitals in the area, figuring out how to, go past hospital organizational lines to work together to transport these patients, I think is just a hugely important, albeit sometimes politically challenging thing that needs to happen within our nation. There have been efforts to move staff, to move supplies, and those are good and those are necessary. But sometimes the space itself has reached its physical limits, and so you do need to move the patients as well. Those would be the 2 kind of high-level comments I had. Of course, there's, I'm sure, scores of questions out there that we'll hear from.
Yeah, scores, pages and pages. Okay, and we can't get to all of them. Thanks very much, Dave. But when I say it's a frustrating role to see so many questions that are really good and we can't get to them all. And there's one, I'm going to ask each of the current speakers and Dr. Yaffe, who was our speaker at the last emergency department rounds, one question, and then I'm going to turn it over to Sandy and Mike to either pose a question or comment on what they're seeing among emergency nurses and emergency physicians in the nation. Okay, so this question, I'm going to read the question, but let me frame it first. That would be the communication speaker, and I'm going to frame this a little bit. So what has clearly evolved in patient care in response to COVID-19, as we've learned and been crushed by, is the challenge around ventilation management strategies. And we actually had a special session on that. For the emergency department specifically, the issues of ventilation support. And I'm going to read the question, then what I'd like is your responses, and this is how we're doing it now, okay? Realizing it may have changed quite a bit. So, and I need like lightning rounds, like checkout rounds where, you know, you got a bus crash coming in with a bunch of people and you only got like 10 minutes before you can get checkout done. All right, so you've already all been there. Okay, so the question is, are there certain parameters, indices being used by our colleagues here of when to institute mechanical ventilation versus self-proning versus non-invasive ventilation, BiPAP, CPAP? Initially, we thought we should intubate many of these patients, and now we are not so quick to pull that trigger. I'm curious as to what other institutions may be doing in their course of care and approach. So, Anna, yeah, your turn. And then I'll go to Mike and Eric.
Yeah, that's a great question. That's something I think everyone's struggling with. So right now we've transitioned from early mechanical ventilation to looking at the patient's clinical status, their respiratory rate, and their work of breathing. And if they are not having a terribly increased respiratory rate or work of breathing, we're trying non-invasive ventilation like high flow nasal cannula or face mask and self-proning, and then leaving the intubation to those patients who are really in extremis.
Okay, thank you. And Mike.
Very similar. 2 weeks ago, we had an early intubation push. Last week, we weren't so sure. This week, we do have a stepwise approach where we're looking to target saturation somewhere around 86 to 88%. We will initiate supplemental O2 with nasal cannula up to the 4 to 6 liters range. We'll then move to high flow nasal cannula or CPAP in a negative pressure room. And we will put masks, surgical masks, over that non-invasive therapy. I will tell you that internally, our group, our critical care group across the system, from a high flow nasal cannula standpoint, will go probably to about the 30 liters per minute. And once folks need an FiO2 above 70 to 80%, then we feel that we are moving closer to mechanical ventilation. But like everyone, and like Anna said, we've pulled back on the thrust of early intubation.
Thank you. And Eric, Dave?
Yep, not much to add to what Anna and Mike mentioned. I do say we do encourage patients, actually we even encourage patients who are discharging to do as much prone positioning as they can. So we are, very early on the prone. So people are proning with nasal cannulas, with non-rebreathers, with high flows, with CPAPs. If proning is not possible for reasons pertaining to the equipment or the body habitus, then at least sort of shifting the positions to the right and left lateral decubitus positions. We are, just as mentioned, trying to do everything to avoid putting the endotracheal tube down the patient for the reasons discussed.
Thank you. And when you say, Dave, when you said try to prevent intubating as much as possible, is that like continue on in your critical care units as well, that philosophy, or is like we're just trying to like stop from intubating in the ED?
No, that does continue. We are in close conversation with our critical care council and our internal medicine council as well. Everyone is sort of kind of going with the same philosophy. That philosophy was, as discussed, 180 degrees different 3 weeks ago than it is now, but we are all sort of pivoting and following the same approach. So people will generally go, on CPAP up to the ICU, and they'll try to stave off intubation up there as much as possible as well. We are, I would say, increasingly heavily reliant on CPAP. What a marvelous, marvelous resource.
Yeah, for sure. I'm gonna, let's see, there's a question very specifically related, then I'm gonna turn it over to Mike and Sandy. hang on. Is it safe to do high flow nasal cannula, non-invasive positive pressure ventilation in a normal room with patient in a mask, as in a not negative pressure room? What are your thoughts on that? Anybody?
Well, I can say
Yeah,
what
Mike.
we do is we place all of these folks preferentially in a negative pressure room, but understand that we only have a certain amount of negative pressure rooms. And so when we have occupied all of them, we do still, for the patient treatment, place them in a non-negative pressure room, but ensure that door is closed and really minimal interaction and involvement in the room as possible. We all have a limited and a finite resources of negative pressure rooms. So that's what we do when we run out of negative pressure rooms.
Thanks. Let's see, Mike and Sandy, the question is, you've been along on this ride with us on Project Echo since we began the ED rounds. And I guess the question is, like, what are you seeing today that everyone, I mean, there's probably about 800 people on this call, everybody should know from an emergency nurse's perspective, and then same for emergency medicine? Mike, gotta unmute. There you go.
How about there?
I do it all the time. Bruce will tell you.
You know, one of these days I'll get this. You know, all this new technology we got to use now these days, right? So yeah, I mean, just really, I mean, from the nursing perspective, even from the provider's perspective, it's all about trying to stay up on top of the changing information, right? And so how do you can get that information to your members, to your frontline staff, so that way they understand what the new protocols are, or anything like that that's changing. So, I mean, I think that's the hardest thing, is just to make sure that you are able to get that information down so that everybody can get that information, you know, at the start of their shift. And sometimes, you know, things change mid-shift as new things come out, new policies or whatnot. And so how do you make sure that everybody's staying on top of that and making sure that they're staying healthy as well?
Yeah, thanks, Mike. Sandy?
So I have never been prouder to be an emergency physician, and I think everyone at ACEP absolutely now understands the mission, and they cannot be prouder of all of you. I just cannot, I'm just overwhelmed by the bravery, by the willingness to respond. It's like the firefighters running into the burning building scenario, except that's us. We've never had a whiter hat than we have now. I cannot, I'm overwhelmed. A few things we recognize that you guys need information, and if I can share the screen for just a second. I hope
Yeah.
Yay, there it is. So this is our field guide, we're calling it. It's the fastest textbook I've ever written in my life. It was written in 2 weeks from start to finish. I hope you find this to be helpful. In addition, acep.org COVID-19 has a ton of resources. We realize that right now you guys are probably just tired, absolutely just tired. And so we're trying to think of the things that we can do. We've partnered with Hilton. We've reached out to Hilton and Marriott and a bunch of other hotel chains, and they have responded with free rooms, recognizing that our nurses, doctors, et cetera, just sometimes need a place to go to decontaminate, to unwind, to get away from it all. They're there for the responders that have been coming into New York City, and we're grateful for that. We also have things like we reached out to some of the food deliveries, and they're all cooperating with us. And so there's a whole list of stuff on acep.org/COVID-19. Please look at it. There might be stuff there you need, pet supplies. As we reach out to these companies, and it's our amazing staff at ACEP that reaches out to these people are just lining up to help you guys. They realize, again, your white hat has never been whiter. We've also standing up things for people who want to respond to the hot areas. One of the bizarre things about this is while we have hot areas where there's simply not enough staff, we have cold areas in this country, and volumes are down 40% in some locations. And so we have a lot of docs who are now out of jobs. It's bizarre. I mean, this is crazy. And they are looking to pick up shifts somewhere, and we are trying to help them with all of the opportunities that are out there. And I would be remiss to say that there are some people who are now trying to make this to their advantage. And so many of the insurance companies are trying to get balanced billing legislation through now, so that when we do get back to some form of normalcy, we won't be able to negotiate with them about rates. So it's like, you know, are you kidding? Are you kidding me? Do you not realize what we're doing out there? Anyhow, ACEP has your back. We've been working with the American Heart Association, American College of Cardiology, the NIH, just a litany of people. But it all comes down to the fact that what you guys are doing is why ACEP exists. And if ACEP can help you in any way, please just get in touch with me. It's very easy. It's my first initial last name at acep.org. And we'll try to figure out a way to help you guys. I could not be prouder this amazing work you guys are doing. Thanks, Rick.
Thanks very much, Sandy. Sandy, if you could unshare the screen, that'd be great. I love the field guide, and extraordinary resource pulled together in a very rapid fashion. I have one lightning rounds question for the speakers and our past speaker, Anna from Emory. Lightning round, real quick, okay? So for your departments, what's been the single best thing that has supported the health, including mental health, of the emergency department staff, including physicians, nursing, and the rest of the staff? Starting with Mike.
I'm going to have to say just the support of one another. I've never seen our ED and our community come together like it has during this time. And we know that some of the small businesses around the medical center and our system are having a really tough time. And having said that, they support us with food, meals, all sorts of stuff that has been amazing, to the point that I almost feel guilty accepting it, because I know they're struggling, but to look around and seeing how everyone is looking after one another, supporting one another. We have a variety of specific things, but it's just the true team atmosphere. When you see it on the TV, you know, in it all together, I can truly say that we feel that in our ED.
Thanks, Mike. Anna?
I would agree with that. One thing I would add is reassuring our staff and providers about our PPE chain. I think a supply chain has been really helpful. There was a lot of anxiety initially about a PPE perceived shortage, and having that reassurance has been really helpful.
Yeah. Eric and Dave?
Yeah, I would say, actually I have two quick things. I would say the PPE is definitely an issue. We got hit so early. Everyone was still, you know, looking and saying, well, gosh, CDC and WHO are recommending surgical masks. And the ability to sort of nimbly position is sort of, again, saying, hey, look, everybody in these areas needs to be wearing an N95. We were able to do that before almost all of our hospitals sort of reached that inflection point, headed up on the surge. Second thing I think is just having leadership at the facilities. We've had some of our ED chiefs have worked 3 straight weeks in a row, and so, you know, for the frontline staff to feel that they are working alongside you know, their bosses, I think, who are in the trenches with them, that's, you know, immensely uplifting as well. So, you know, props to the leadership at the facility as well. That can't be overstated.
Yeah, I'll just add, Rick, I'll add 2 things to that. So one is communication. They want to feel like they're in the conversation, they're hearing the same information that their leaders are hearing. And so many of our ED chiefs and their teams have created WhatsApp groups with their faculty, holding kind of open WebExes with their residents on a twice weekly basis, so they can ask all their questions and get them answered straight from the source. And I would agree with Mike in terms of the crisis has brought out so much good in humanity and restored faith in humanity. We've had close to $20 million worth of monetary and good in-kind donations, anywhere from Girl Scout cookies to 3 hot meals a day to all of our our staff in all 16 of our facilities. And it's just been amazing how the community has rallied around our healthcare workers.
Thanks very much, all. Before I close, I want to turn it over to Dr. Struminger for any final comments.
Thanks, Rick. Just want to thank Mike and Eric and Dave and Anna for joining us, and Sandy. It's been a great session, and want to remind everyone, if you can, please take advantage of the CME and nursing credits and give us your feedback so we can keep improving these rounds, and join us next week.
Thanks, Bruce. With that, there's one phrase that popped up in this peer-to-peer learning session that struck home with me. One system to save lives, and goodness gracious, if emergency departments, emergency physicians, nurses, and their staff, don't forget the housekeepers. Wow. Singularity of purpose goes a long way. Thanks to all of you, our participants, our panelists, and our speakers, Project ECHO, NETEC, and others, and especially our international participants who have joined to learn right along with us. Thank you so much, and we'll see you on the next one. Bye.